Hi and welcome to another video. Today I'll go over Molluscum Contagiosum. I'll firstly talk about the key background information to be aware of, then go over the clinical presentation before diving into the investigations and subsequent management. So, most importantly, Molluscum Contagiosum is also known as water warts, and it is a viral skin infection resulting in pink lesions with a dimple in their center. It is caused by a poxvirus, the Molluscum Contagiosum virus. There are many different subtypes of said virus, but I will not be diving into those in this video. The condition affects up to 5% of the population worldwide, and it is more prevalent in warm and humid climates. It is typically transmitted through direct skin-to-skin contact, and the incubation period can be anywhere between 2 weeks and 6 months. But what are the actual clinical features of the condition? Most importantly, there are pearly papules that have a central dip, and they are often waxy or shiny in appearance. There might be some erythema around the papules, but that is typically appreciated on lighter skin and might be difficult to see on darker skin. And in fact, it might not have to be present at all. Here are some photos of the condition. All of the photos are from dermnetnz.org. And as you can see on this photo on top right, there is a red papule roughly 5 millimeters in diameter with a central dip that has a bit of a shine or a waxy look to it. On darker skin, here you can see you might not appreciate the color, so they might not appear as red and there might not be any erythema around it, but they still appear waxy and they should still have a central dip, which should help with the diagnosis. It can present anywhere on the body, so on the photo in the bottom left, here it is on someone's face with some of the erythema around some of the nodules. And in some cases, the condition may be itchy and patients might itch themselves. And when that occurs, it may result in the papules forming along the scratch when the patient has caused it to spread. With regards to the investigations, your first line would be a dermoscopy, which is often diagnostic. However, if there is any clinical doubt, you may perform an H&E staining on the biopsy of the lesion, and it would show Henderson-Patterson bodies, which are diagnostic. Those bodies are intracytoplasmic eosinophilic inclusions that have the virus particles inside of them. You can appreciate them most often on the dermoscopy itself, so you can see them here, and therefore H&E staining and biopsy is not often required, especially if the clinical picture fits with this diagnosis. But how do you treat it? Well, often watch and wait may be the right approach, particularly if the patient is not bothered by the lesions and does not have many lesions, as most lesions disappear by themselves within 18 months in patients who are not immunocompromised. Topical ointments may be used, such as potassium hydroxide and salicylic acid creams, or cryotherapy if the lesions cause distress or the patient has not responded to topical ointments. Furthermore, prevention strategies should be discussed, such as covering visible lesions and practicing safe sex or abstinence, particularly if there are lesions in the genital area, and the patient should avoid sharing things like towels, which might be wet, and increase the spread of the virus to other people. That was a very brief overview of the condition. If you have any questions, feel free to leave them down in the comments. That is from me. Thank you so much for watching.